in combination with LASIK, why are we not putting the drops directly over the flap? One of the reasons is cross-linking the flap itself is not really going to provide any advantage, any biomechanical advantage, as it doesn't contribute to the biomechanical strength in the post-operative period. But importantly, cross-linking could theoretically cause a certain flap shrinkage and improper apposition in the post-operative period. Now, looking at the outcomes, it is studies have shown that there is a greater refractive accuracy, that is, the amount of regression seen at 1 year tends to be lower in high myopic patients. This is certainly more impressive when it comes to hyperopic patients, that at 2 years out, that the amount of regression when combining it with the treatment for hyperopia, the eyes which have been cross-linked have had a much lower incidence and the amount of regression. Again, because we're doing a short accelerated cross-linking for a brief amount of time, we don't see any progressive flattening which happens over a period of 12 months, and it has been shown that there is no subsequent flattening and no refractive effect or no hyperopic shift with this strength of cross-linking. Finite element models have also shown that the cross-linked cornea is stronger in the post-refractive surgery period. Now, how does this matter when you are actually talking about regression? Now, with regards to regression, one of the hypotheses is that you have a forward shift of the cornea or a forward bowing of the cornea, and that is primarily related to the IOP. So, in an experimental state, they have shown that in a cornea where only LASIK has been performed, shows a far greater protrusion when the IOP is raised from 15 to 30. The forward protrusion is far greater, but when it is a cornea which has also been cross-linked, the amount of protrusion with the raise in IOP is significantly lower. Again, moving on, with the advent of the accelerated cross-linking, you also have various newer modalities which have come up, that is both in terms of customizing your cross-linking, delivering various zones of energy, which Gitansha will explain to you in detail, but all this has been made possible only with the advent of accelerated cross-linking. Even tuning up of refractions, small myopic corrections, again pixel which will be detailed upon, is all possible now. This higher amount of energy is all possible only with the advent of accelerated cross-linking. So to summarize, accelerated cross-linking seems to be effective. Definitely needs a longer follow-up when you're doing it in pediatric patients, young patients. Going in for the more accelerated forms, we need to watch out. Probably if I had to give one take-home message, among all the accelerated protocol, the general consensus now seems to be that a 9 milliwatt for 10 minutes, just for the purpose of arresting keratoconus in children, seems to be probably a good balance in terms of time and the amount of fluence we are delivering to the cornea. Thank you so much for your kind attention. So if there are any queries, I'll be happy to take them. And in the meantime, I'd like to invite on stage Dr. Ritika Sachdev, who will then be detailing upon another difficult sector which we have when it comes to deciding upon cross-linking in keratoconus. What happens when the cornea is too thin for conventional cross-linking? What are the options and how do we go about choosing them? Ritika.
Thank you, Shrey. It's a pleasure to be part of your course. Could I have my slides, please? So basically, a thin cornea for the purpose of cross-linking is defined as 400 microns. Why that is so is the damage threshold for ultraviolet light, that means the thickness at which the damage to the endothelium will not be there, in studies has been found to be 400 microns. So you must have 400 microns of corneal tissue to safeguard the endothelium from the ultraviolet light. How do we go about this? In a patient who has keratoconus, naturally the cornea will be thinner. It has been shown by Pearson et al. That in Asians than countries like ours, the onset of keratoconus is earlier. So we often encounter in our practice more advanced cases of keratoconus, wherein the thickness would be less than 400. Remember, this thickness of 400 is after removal of the epithelium, because you normally debride the epithelium in the cross-linking procedure. So you really need a thickness of close to 460 or 470. Now, how do you cross-link the thin cornea? In order to add to the thickness while cross-linking, you can use two approaches. The first is that you preserve the epithelium, because preserving the epithelium will give you additional thickness of close to 70 microns. However, transepithelial cross-linking is only 1/5 as effective as conventional cross-linking. Therefore, there are downsides to this approach. How can you move around this? There is a technique advocated by Mazzato et al. Wherein they say that you should do partial epithelial debridement. In the area which is the thinnest, you leave the epithelium on, and in the rest of the area you remove the epithelium. Removing the epithelium helps more oxygen and riboflavin go into the stroma and makes the cross-linking much more efficacious. And in the thinnest part, the epithelium being on safeguards it and makes it the 400 microns that you need. Another attempt to make trans-epithelial cross-linking more functional is the use of ICXL. Riboflavin itself is a small negatively charged molecular weight compound, and giving a small degree of current allows riboflavin to penetrate through the intact epithelium and makes trans-epithelial cross-linking more effective. And in studies it has been found that this technique is quite successful in stopping the progression of keratoconus. Now, what is the second approach if you have a thin cornea is that you can, after removing of the epithelium, try to add to the stromal thickness to temporarily make it 400 microns so that you can irradiate it safely. The first approach to this was advocated by Hafizi et al. What they said is that after removing the epithelium, if you use a hypoosmolar solution, you swell up the stroma, right? Because any corneal tissue after epithelial removal swells up quite quickly. The normal riboflavin that we use is 0.1% riboflavin 5-phosphate, which is mixed in 20% dextran. However, this is the isoosmolar solution. The hypoosmolar solution is 0.1% riboflavin 5-phosphate made in 0.9% NaCl or sodium chloride. So what we do is, after epithelial debridement, we continue to put the isoosmolar, the normal riboflavin, for 30 minutes like we do normally. Then we do a pachymetry, and if we feel that it is shorter than 400, continue to put the hypoosmolar solution. Note that the hypoosmolar solution needs to be put much more frequently, every 20 seconds. So because it stays on the cornea for a shorter time. What does the hypoosmolar solution do? It swells up the stroma. Studies have shown that you can swell up the stroma up to 100 microns. So effectively a 300 micron bed can be swollen up to 400 microns. What happens is that the proteoglycans which are there between the collagen fibrils take up the hypoosmolar solution and swell up the stroma. However, there are some people who are also using distilled water instead of hypoosmolar riboflavin. That is not to be encouraged, because when you use distilled water, you're reducing the concentration of riboflavin. So it is better to use hypoosmolar plus isoosmolar riboflavin as a combination rather than isoosmolar riboflavin and distilled water. Another approach advocated by Dr. Susan Jacob et al. Said that if you remove the epithelium and you have a sub 400 micron stromal bed, what you can do is just take any normal contact lens which is UV barrier free. That means it does not absorb UV light, because you want the UV light to move through the contact lens. So you can use a soft lens by Bausch & Lomb. It has to not absorb the UV lens. You soak the cornea and the contact lens separately. Prefer to use not the dextran dye but the riboflavin and HPMC dye for this. And after soaking it for 30 minutes, you put this contact lens over the cornea and irradiate it normally. The additional thickness of the contact lens and the tear film will give you the added thickness that you need to make this stroma 400 microns. However, in studies it has been shown that if you're doing the hypoosmolar technique, the efficacy of cross-linking is reduced by nearly 6 to 7%, and CXL or contact lens assisted CXL reduces the efficacy by 20%. However, these are still efficacious enough to stop the progression of keratoconus. A modified technique which was published by us in JCRS was the use of the SMILE lenticule. Now, if you've seen the SMILE surgery, when you do a myopic correction, you remove stroma. You can use this stroma to put on the stromal bed after epithelial debridement for the irradiation. This lenticule is thickest in the center and thin in the periphery.